Hello everyone, I am Dr. Trupti. Welcome to my YouTube channel Enjoy Biochemistry. In today's video, let's learn about vitamin A. At the end of this session, students shall be able to describe vitamin A with respect to its dietary sources, RDA, biochemical functions, deficiency manifestations and its toxicity. Vitamin A is a fat-soluble vitamin and it is an essential nutrient for animals. This term vitamin A, it is a group of chemically related organic compounds and this group includes retinol. This is the alcohol form of vitamin A. Retinal, it is aldehyde form. It is also called as retinaldehyde. The oxidized form is called as retinoic acid. And the carotenoids. There are various carotenoids like alpha carotene, beta carotene and gamma carotene, out of which beta carotene is most commonly found in the plant foods. So these all four forms, retinol, retinal, retinoic acid and beta carotene, these are forms of vitamin A. The alcohol form retinol, it has a role in reproductive system, while retinal plays a role in normal vision. Retinoic acid has a role in growth and cell differentiation, while beta carotene acts as an antioxidant. Retinol is an active form. It is present in foods of animal origin, while beta carotene, which is a provitamin, it is present in plant tissues. The retinoids include both natural and synthetic forms of vitamin A, and the retinoids include retinol and retinoic acid. And these three forms, retinol, retinal and retinoic acid, they are also called as vitamins of vitamin A. What are vitamins? Vitamins are chemically similar substances that have a qualitatively similar vitamin activity. So all the three forms, retinal, retinol and retinoic acid, they are chemically similar substances and they have qualitatively similar vitamin activity, and that's why they are called as vitamins of vitamin A. Now let's see the chemistry of vitamin A. This is the structure of retinol having beta ion ring. This is the cyclohexenyl ring, and this beta ion ring, it is responsible for biological activity of vitamin A. And the side chain of this retinol has unsaturated isoprenoid units and it has 4 double bonds and 1 hydroxyl group. Retinol is present in animal tissues as retinyl ester with long chain fatty acid. On oxidation, retinol becomes retinal, that is the aldehyde form of retinol. It is also called as retinaldehyde, and both forms, retinol and retinal, they are interconvertible. Retinol can be reduced to retinol. Further, this retinol can be oxidized in the body to form retinoic acid. But this retinoic acid cannot be converted back to retinal or retinol. Now this beta carotene, this beta carotene has 2 beta ion ring joined by polyisoprenoid units, and in intestine this beta carotene is hydrolyzed to give 2 molecules of retinol. Coming to the dietary sources of vitamin A, the form of vitamin A which is present in the animal sources is retinol, and the richest sources of retinol are fish liver oil, that is cod liver oil, shark liver oil, milk, butter, cream, cheese, egg yolk, and provitamin form, that is beta carotenoid, it is present in the plant sources. There are various types of carotenoids, alpha, beta and gamma, but beta carotenoid is most common and most abundant form of carotenoid which is present in the plant sources, and it is found in yellow and orange color fruits and various vegetables like carrot, papaya, mango, pumpkins and various green leafy vegetables. So these are the dietary sources of vitamin A. Daily requirement of vitamin A is expressed as retinol activity equivalent, that is RAE or microgram. So 1 retinol activity equivalent is equal to 1 microgram of retinol or 2 microgram of beta carotene. So the daily requirement in adult men is 750 to 1000 microgram per day. In women it is 750 microgram per day, and in pregnancy it is increased to 1000 microgram per day. In children it is 400 to 600 microgram per day. Now let's see how vitamin A is digested, absorbed and transported in the body. So we consume vitamin A in the form of beta carotene and retinol esters. Beta carotene is derived from the plant sources and retinol in the form of retinol esters we get from the animal sources. Bile salts play a very important role in digestion and absorption of vitamin A. Bile salts are required for emulsification, which helps in the digestion, and then micelle formation is required for absorption of both beta carotene and retinol. So beta carotene, with the help of micelles, it is absorbed in the intestinal cell. In the intestinal cell, it is hydrolyzed by dioxygenase enzyme to form two molecules of retinol, that is retinaldehyde. Further, this retinol is reduced to retinol and later on it is esterified. Likewise, retinal esters, that is retinol along with long chain fatty acid which are present in the animal sources, they are first hydrolyzed to form retinol and free fatty acid by action of enzyme pancreatic hydrolysis. Then the retinol which is released from this retinal esters, it is taken up by the intestinal cell with the help of micelles. So here bile salts play a very important role. Once inside the intestinal cell, the retinol is esterified and there is formation of retinal esters. Now these retinal esters are transported to the liver with the help of chylomicrons, so via lymphatics. So chylomicron is important for transport of the retinal esters to liver. Then these retinal esters are transported in the liver and 90% of the retinal esters are stored in the form of retinal palmitate. And when the need arises, this retinol is released from the liver and transported to various tissues in bound form with the retinol binding protein, that is RBP, and transthyretin, which is also called as prealbumin. So there is a formation of trimolecular lipoglycoprotein complex. So this complex has retinol, retinol binding protein and prealbumin. And this molecular aggregate of relatively large size, it prevents the loss of vitamin A by glomerular filtration, and it also ensures the taking over of retinol by specific cell receptors which recognize this complex. So with the help of this tricomplex, then in the circulation the vitamin A reaches to various target tissues. Through the circulation, the retinol reaches the target organs like retina, skin, gonads and other tissues. The mechanism of action of retinol or vitamin A is similar to that of steroid hormones, and it acts through intracellular receptors. The intracellular receptors through which this vitamin A acts are located in the nucleus. So these are the intranuclear receptors, and these nuclear receptors are retinoic acid receptor, that is RAR, and retinoid X receptor, that is RXR. So once this trimolecular complex through the circulation reaches to the target tissue or target cell, then this retinol binding protein is released from the complex and retinol is taken up by the cell. And in the cell cytosol, this retinol combines with cellular retinol binding protein and it forms a complex retinol CRBP, that is cellular retinol binding protein. Then this retinol is oxidized to retinal and further retinoic acid, and there is formation of retinoic acid and which combines with the cellular retinoic acid binding protein CRABP. This retinoic acid can enter the nucleus, so it enters nucleus and it forms a complex with RAR and RXR, so it interacts with the nuclear receptors and these nuclear receptors then interacts with the target gene, and after interaction there is transcription of the target gene and there is formation of RNA. Further, through the translation, specific proteins are synthesized which are required for the various functions carried out by vitamin A like morphogenesis, cell differentiation, growth, etc. So this is the mechanism of action of vitamin A, which is similar to steroid hormones, and this vitamin A acts through nuclear receptors. Vitamin A performs various biochemical roles in the body. So this vitamin A has role in normal vision, that is retinal is important for vision. Retinol is important in reproduction. Retinoic acid is required for growth and differentiation. Immunity, that is the immunological system. Vitamin A perform a very important role in maintaining the immunity. Epithelialization and beta carotene acts as an antioxidant. Various other functions are also carried out by vitamin A like transferrin synthesis, gluconeogenesis and cholesterol synthesis. Vitamin A plays very important role in vision, which is explained by Wald's visual cycle, which was described by George Wald, and he received Nobel Prize in 1967 for that. This is the structure of eye and this is retina. There are various cells present in the retina. Photoreceptor cells are also present there, and these photoreceptor cells are rods and cones. These rods, this is the rod and this is cone. So the outer segment of a rod has disc-like structure which has the pigment rhodopsin, which is made up of opsin plus 11-cis retinol, and it is responsible for vision in dim light. While cones also have the opsin component, there are three types of opsin component: synopsin, iodopsin and porphyropsin along with the 11-cis retinol, and it is responsible for vision in bright light as well as color vision. So when light falls on the eye, it travels from the cornea, aqueous humor, pupil, then vitreous humor and finally falls on retina, and it triggers a series of biochemical events that leads to generation of nerve impulse. And George Wald and his associates studied this phenomena of biochemical and photochemical events in detail, and this cyclic event is popularly known as Wald's visual cycle. Now let's see the various events of Wald's visual cycle. The events occur both in rods and cones, but here we are trying to understand with the help of the events those occur in the rods. This is the rod, this is outer segment of rod. It has disc-like structure. This disc-like structure has rhodopsin in it. And it also has cyclic GMP dependent sodium and calcium ion gated channel. This rhodopsin, it is made up of 11-cis retinol plus opsin. So this 11-cis retinol, on exposure to the light, it is isomerized to form all trans retinol, and there is formation of series of unstable intermediates like bathorodopsin, lumirodopsin, metarhodopsin 1 and metarhodopsin 2. This process is called as bleaching process. Now this metarhodopsin 2, it is the activated rhodopsin, and this activated rhodopsin excites the electrical changes in the rods, and then the rods transmit the visual image into central nervous system in the form of optic nerve action potential through the process of phototransduction. And this phototransduction process, it is the process by which absorbed light triggers an electrical response, that is the neural signal in rods and cones, and which is responsible for generation of nerve impulse and the generation of visual image. Now this all trans retinol which is formed here has to be converted into 11-cis retinol. So the regeneration of 11-cis retinol is very important from here to complete this Wald visual cycle. The opsin remains in the retina, but this all trans retinol, it goes into circulation and then regeneration occurs. So now we will see how the regeneration of 11-cis retinol occurs from all trans retinol. So we have seen that on exposure to the light, photoisomerization and visual excitation occurs. The 11-cis retinol of rhodopsin, it is isomerized to all trans retinol and opsin is released here. Now some amount of all trans retinol can be isomerize to 11-cis retinol in the retinal epithelium by the action of enzyme retinal isomerase. So this 11-cis retinol now can combine with the opsin to form rhodopsin. And most of the all-trans retinol, it is transported through circulation to the liver, where in the liver this all-trans retinol, it is reduced to all-trans retinol by the action of enzyme alcohol dehydrogenase. This is zinc dependent enzyme. Now this all-trans retinol can be isomerized to form 11-cis retinol in the liver by action of enzyme retinol isomerase. Further, this 11-cis retinol can be oxidized to 11-cis retinal by the action of enzyme alcohol dehydrogenase in the liver. And when rhodopsin is to be resynthesized in the retina, this 11-cis retinal is transported through the blood to the retina, where it combines with the opsin to form rhodopsin pigment, and it is ready for one more visual cycle on exposure to light. So this regeneration of rhodopsin for visual activity, it is called as walled visual cycle or rhodopsin cycle. Now let's see how phototransduction takes place. Phototransduction is the process by which the absorbed light trigger an electrical response, that is neural signal, in rods and cones. So this is the rod, outer segment. This is outer segment cell membrane. It has various disc shaped structure, and this is one of the disc. It is the disc membrane. The disc has rhodopsin. Rhodopsin is a G protein coupled receptor. Rhodopsin is made up of 11-cis retinal and opsin. It is associated with the G protein, that is transducin, which has 3 subunit alpha, beta and gamma, and inactive form is associated with GDP. It also has cyclic GMP phosphodiesterase enzyme, and inside the cell there is cyclic GMP. So during the dark, the concentration of cyclic GMP is high, and there is entry of sodium from the cyclic GMP gated sodium and calcium channel is there. So there is entry of sodium during the dark period. But when light falls on the or reaches the retina, it activates the rhodopsin. Then the rhodopsin is converted to meta-rhodopsin 2, which is activated rhodopsin. This meta-rhodopsin 2 then activates the G protein, that is transducin, and then GDP is replaced by GTP. So now it becomes activated, and the activated form of this transducin, there is release of this alpha subunit associated with GTP from the rest of beta and gamma subunit. This alpha GTP then binds with the cyclic GMP phosphodiesterase enzyme. It activates the enzyme which causes conversion of this cyclic GMP into 5' GMP. Now the concentration of cyclic GMP inside the cell is decreased, and because of that the sodium channel is now closed. So there is no entry of sodium inside the cell. So there is less positive charge inside, and it leads to hyperpolarization, and further it results in the neuronal signaling. Now how this phototransduction is terminated. So termination of phototransduction takes place in various ways. First, by the phosphorylation of this meta-rhodopsin by rhodopsin kinase, and second way is binding of arrestin. It is also a protein to this meta-rhodopsin. Again, this transducin has intrinsic GTPase activity. So because of that activity, that GTP gets converted back to GDP and it becomes inactive. So this is how the termination of phototransduction occurs. So these are the various events of visual cascade of phototransduction that occurs in the disc membrane, which involves G protein coupled receptor rhodopsin, G protein transducin, cyclic GMP phosphodiesterase, and ultimately the concentration of cyclic GMP is reduced by activation of this phosphodiesterase enzyme by the transducin, which leads to hyperpolarization and then neuronal signaling. So there are 5 steps of phototransduction. First, there is activation of rhodopsin to meta-rhodopsin, which is followed by activation of transducin. Then there is activation of phosphodiesterase by the activated transducin. hydrolysis of cyclic GMP to 5' GMP, which leads to the closure of sodium ion channels. So because of less entry of sodium in the cytosol, it results in the hyperpolarization and further neuronal signaling. What is dark adaptation? We know that rod cells are more sensitive to light, and in bright light all rhodopsin store is depleted in the eye to prevent its overstimulation. So when the person suddenly shifts from bright light to the dark area, for example in the cinema theater, it takes some time to get the vision, and time taken to get vision in dark is called as dark adaptation time. It is the time required to resynthesize the rhodopsin pigment. And if there is vitamin A deficiency, the vision in dim light is decreased, which is called as night blindness, and the dark adaptation time is increased. Vitamin A also has role in growth and differentiation of tissues. All trans-retinoic acid, 9-cis retinoic acid, they act through the nuclear receptors RAR and RXR, and they regulate the gene transcription, result in the translation of specific protein required for the cell differentiation. And this process is very important for the embryogenesis, differentiation of 3 germ layers, and organogenesis. The retinoic acid is also involved in the sulfation of mucopolysaccharides present in the bone and cartilage. That's why vitamin A has a very important role in bone formation as well. Retinol is essential for reproductive system. It supports spermatogenesis, prevents fetal resorption, and controls expression of certain genes during embryogenesis. So if there is vitamin A deficiency, it can lead to infertility. Beta carotene acts as an antioxidant, and it removes the peroxyl and free radicals from tissues under anaerobic condition. It decreases the risk of certain cancer, for example lung cancer, and intake of beta carotene has been associated with the decreased incidence of heart disease, lung and skin cancer. It is also associated with the decreased risk of cataract. A is also required for maintenance of immunity because the retinoic acid has a role in differentiation of T cells into regulatory T cell. So if there is vitamin A deficiency, there is decreased population of hematopoietic stem cells. Vitamin A also has effects on skin and epithelium. It is required for maintenance of normal epithelium and skin. 11-cis retinal inhibits the keratin synthesis. So if there is deficiency of vitamin A, it leads to keratinization of epithelial tissues of the skin, respiratory mucosa, gastrointestinal and genitourinary tract, and it interferes with the normal functioning. It is also involved in the glycoprotein synthesis. Glycoproteins are the constituent of mucus. So if there is vitamin A deficiency, it results in dryness of epithelial tissues. Various other functions performed by vitamin A. For example, vitamin A, retinoic acid and retinol, they are required for transferrin synthesis, which is iron transport protein. It is also required for gluconeogenesis because corticoids which are secreted by adrenal cortex, they are essential for gluconeogenesis. And in case of vitamin A deficiency, there is degeneration of certain cells in the adrenal cortex and the levels of corticoids is reduced, so it affects gluconeogenesis. It also has a role in cholesterol synthesis. Cholesterol synthesis requires vitamin A. Mevalonate is an intermediate in the cholesterol biosynthesis, and this mevalonate, it is diverted for the synthesis of coenzyme Q if there is vitamin A deficiency. So these are the various functions of vitamin A. Now coming to the vitamin A deficiency, the deficiency of vitamin A manifests only if the diet is devoid of vitamin for a period of 2 to 3 months and the hepatic stores are sufficient to meet the requirement for a long period. Now what are the various causes of vitamin A deficiency? So there are primary causes and secondary causes. The primary causes include if the dietary intake is less, in case of low birth weight in preterm infants. And which are the secondary causes? The first secondary cause is obstructive jaundice. Here in obstructive jaundice, the absorption of vitamin A is defective. Celiac disease and pancreatitis. So here the absorption, digestion and absorption is defective. In case of cirrhosis of liver, the retinol binding protein synthesis is reduced, and in nephrosis, the retinol binding protein is lost through the urine. So these are the various causes of vitamin A deficiency, both primary and secondary. The deficiency manifestations of vitamin A are mainly seen in the eyes and skin, and in the eyes the deficiency manifestation includes night blindness, xerophthalmia, Bitot spots and keratomalacia. So the first one is night blindness. It is also called as nyctalopia. The night blindness is difficulty for the eyes to adjust to the dim light, and people with the night blindness, they have poor vision in the darkness, but they can normally see when the adequate light is present. Vitamin A deficiency leads to decreased amount of rhodopsin in the eye as retinal is inadequate to bind with the opsin. Here in the night blindness, dark adaptation time is prolonged. So this is the first deficiency manifestation. The second deficiency manifestation is xerophthalmia. This is the dryness of the eyes due to loss of mucus producing goblet cells in the conjunctiva. So there is dryness of conjunctiva. This xerophthalmia involves xerosis, that is drying and thickening of the conjunctiva and cornea, and the conjunctiva and cornea become glazy and lustreless, and it loses its normal transparency. And because of this, there is dry appearance, and also there is increased risk of infection. So this is about the xerophthalmia. Third, Bitot spot. Bitot spots are slightly elevated white foamy lesions, usually seen on the bulbar conjunctiva, and these Bitot spot, they consist of keratin, which the conjunctiva starts to produce because the deficiency has led to squamous metaplasia, with the cells in conjunctiva becoming more like skin than a mucous membrane. So these are the Bitot spots. The night blindness, xerophthalmia, Bitot spots, these are completely reversible with the supplementation of vitamin A. Then the fourth manifestation is keratomalacia. This is the most severe form of xerophthalmia, and here 1/3 of the cornea is affected. The cornea becomes edematous and thickened, and in the advanced deficiency the cornea becomes hazy and can develop erosions and ulceration, which can lead to destruction, leading to total blindness. So keratomalacia can result in the total blindness. So these are the four important deficiency manifestation due to vitamin A deficiency in the eyes. Xerophthalmia is the deficiency manifestation of vitamin A deficiency, and the WHO classification of xerophthalmia includes various forms of xerophthalmia. The first form is XN form, and here it is manifested as night blindness in children. Second form is X1A. It is conjunctival xerosis. Then X1B, it includes Bitot spots. X2, corneal xerosis. X3A, corneal ulceration or keratomalacia, where 1/3 of the cornea is involved. Then X3B, corneal ulceration or keratomalacia, where more than or equal to 1/3 of the cornea is involved. XS, it is corneal scar, and XF, xerophthalmic fundus. So these are the various forms of xerophthalmia as per the WHO. Deficiency manifestation in skin and mucous membrane. There is phrinoderma, which results from hyperkeratinization of the epithelial lining, the follicles. Here the skin becomes rough. Papules are seen at the site of pilosebaceous follicles, and an associated essential fatty acid deficiency can aggravate this condition. So there can be acne, diarrheal disease, that is keratosis follicularis, follicular epithelium atrophy, keratinization. It can also lead to urinary calculi because of keratinization of urinary tract epithelium. So these are the various skin and mucous membrane manifestation due to vitamin A deficiency. Vitamin A deficiency also leads to growth retardation and infertility. So the growth retardation, mainly the skeletal growth retardation, is due to defective synthesis of chondroitin sulfate. There is one more term, preventable blindness. In Indian children less than 5 years, due to dietary deficiency, this blindness can occur, which can be prevented by single dose of vitamin A. That is the prophylactic measure taken, and it is given to the children who are less than 1 year. Vitamin A deficiency also leads to infertility, that is the sterility in male and conification of vaginal epithelium in female. The ovulation and implantation may occur normally, but placentas are defective and abnormalities in fetus may result in the fetal death. The assessment of vitamin A deficiency can be done by dark adaptation test. The dark adaptation time is increased in vitamin A deficiency. The deficiency can also be assessed by measuring retinol binding protein level in the blood. It is reduced in vitamin A deficiency. The normal level is 3 to 6 mg per deciliter. Serum vitamin levels are also reduced in vitamin A deficiency. The normal level is 25 to 80 microgram per deciliter. The treatment of vitamin A deficiency includes 50 to 60 mg per day or 50,000 to 60,000 international unit per day in the form of oral capsule for the period of 1 to 6 months depending on the severity of deficiency. Now let's see the therapeutic uses of vitamin A. The tretinoin form, that is all trans retinoic acid, it is used in the treatment of promyelocytic leukemia as well as psoriasis. Isotretinoin, that is 13-cis retinoic acid, it is used to prevent acne formation in adolescents. The retinoic acid, it is useful to revert the precancerous condition, that is oral leukoplakia. The condition can be reverted to fully differentiated normal epithelium. And we know that beta carotene is antioxidant and it is helpful to decrease the risk of various cancers like cancer of lung, skin cancer, etc. What is hypervitaminosis A and what are the causes? So if there is ingestion of excess vitamin A more than 30,000 microgram per day for months, so it leads to hypervitaminosis A, and it is due to the side effect of inappropriate therapy of vitamin A. What is the criteria of hypervitaminosis A? The liver storage of retinol or its ester, if it is more than 3000 microgram per gram tissue of liver, and if the plasma vitamin A concentration is more than 140 milligram per deciliter, then we can call it as hypervitaminosis A. The symptoms of hypervitaminosis can be anorexia, headache, drowsiness, vomiting, bony exostosis with painful and swollen bones, dry skin, itching, hepatomegaly or liver cirrhosis in children, alopecia, or there can be fingernail dystrophy like this, and it can also result in congenital malformations. So these are the various symptoms of hypervitaminosis. So far we have studied the theoretical part about vitamin A, that is the dietary sources, various forms of vitamin A, recommended dietary allowance, and biochemical functions of vitamin A, deficiency manifestations, then therapeutic uses of vitamin A and toxicity of vitamin A. Now with the help of a case study we will try to correlate what we have learned in the theoretical part. So this is the case study. A 10-year-old boy was brought to the hospital with history of chronic cough, retarded growth, burning micturition, diarrhea with passing of foul smelling stools, inability to read in dim light and dry thickened skin. On examination, the boy was malnourished, greyish white spots were seen on the conjunctiva and the conjunctiva was dry. So what is the probable diagnosis here? It is vitamin A deficiency. Now what is the justification? In the clinical features, the boy is presenting with all the symptoms of vitamin A deficiency, and the symptoms are like night blindness because there was ability to read in dim light, the skin symptoms, the skin is dry and thickened, the growth retardation is there because of the means it affects the mucus formation, so there is chronic cough, then burning micturition because of as the vitamin A plays role in epithelialization of urinary tract. So whenever there is deficiency of vitamin A, it results in the dysfunctioning with the epithelium of genitourinary tract. So there are various symptoms of vitamin A deficiency. Again, on the examination, the boy was malnourished and the bitot spots were seen on the conjunctiva and conjunctiva was dry. So all these findings, all the findings favor the diagnosis of vitamin A deficiency. Dietary sources, RDA, digestion, absorption, transport and storage, we have already studied in the theoretical part. Mechanism of action of the deficient nutrient. Now the action of vitamin A is like the action of steroid hormone. It acts to the nuclear receptor RAR and RXR and it regulates the gene transcription. Functions, we have seen various functions, the role in vision, role in reproductive system, role in growth and differentiation, role in skin and epithelial tissue maintenance, antioxidant function, various immunological function, and various other functions like gluconeogenesis, cholesterol synthesis, transferrin synthesis, etc. So there are the various functions of vitamin A. Biochemical basis of clinical feature of the disorder. Now, as it performs variety of function, if there is deficiency, it will result in the deficiency manifestations. So that is the biochemical basis, the vitamin A deficiency. Therapeutic uses, we have seen the therapeutic uses of all the forms of vitamin A and effects of excess of this nutrient. So here we have to write about the various symptoms of hypervitaminosis A. So this is the case study of vitamin A deficiency. Now let's see some MCQs of vitamin A. So the first is vitamin A form that combines with opsin to form rhodopsin is. The option A is 11-cis retinol, all-trans retinol, 11-cis retinol or all-trans retinol. Take a pause and try to give the answer. So here the answer is 11-cis retinol. So 11-cis retinol combines with opsin to form the rhodopsin. Deficiency of vitamin A causes A. xerophthalmia, B. riboflavinosis, C. beriberi, D. pellagra. So we know that the deficiency of vitamin A results in the xerophthalmia. Riboflavinosis is due to riboflavin deficiency, beriberi is due to thiamine deficiency and pellagra is due to niacin deficiency. The vitamin having isoprene in its structure is vitamin A, vitamin B2, vitamin C or vitamin D. So we know that vitamin A in its structure has beta ionic ring and isoprenoid units. So it is the vitamin A. The photopigment rhodopsin split during bright light vision, dim light vision, color vision or none of the above. So we know that it splits during bright light vision. The G protein associated with the visual function is. So which is the G protein? Is it rhodopsin, transducin, metarhodopsin or synopsin? So rhodopsin is not a G protein. It is G protein coupled receptors. Transducin is the G protein. So here the answer is transducin. The antioxidant form of vitamin A is it retinol, retinal, beta carotene or retinoic acid? So we know that it is beta carotene. Vitamin A is stored in the option A, retina, liver, bone or kidney. So we know that it is stored in liver. 90% of vitamin A is stored in the liver in the form of retinyl palmitate, and as and when it is required, it is then released in the form of retinol and transported in the circulation in the bound form with retinol binding protein and free albumin. The following are functions of vitamin A except cell growth and differentiation, coenzyme in redox reaction, normal vision and glycoprotein synthesis. So we know that vitamin A has role in cell growth and differentiation, normal vision and glycoprotein synthesis also. So here the answer is B because it is not involved as a coenzyme in redox reactions. The following statements regarding vitamin A are correct except it is the component of visual pigment rhodopsin. Yes, it is correct. It supports cell growth and differentiation. Correct statement. It maintains blood pressure and cardiac output. It is wrong. it participates in the glycoprotein synthesis. It is correct. So here the answer is C. It maintains blood pressure and cardiac output because vitamin A does not play this role. So I hope this video on vitamin A will be useful to you. Thank you for watching and happy learning.